Hello, and welcome to the Dissidents Podcast, where we talk about how we can strive for a world in which freedom and reason are at the forefront of all human society. In 2022, Counterweight, the organization that Helen Pluckrose founded and that was absorbed into the Institute for Liberal Values, had a virtual conference on alternatives to diversity and inclusion. Starting in 2025, we will be rolling out one talk a month that was presented at the conference. We sit down with the original presenters throughout 2025 to see what has changed since 2022. With diversity, equity, and inclusion initiatives seemingly on the chopping block, we are curious to hear what our original participants are witnessing and experiencing on the ground. Is DEI really dead or just in remission? Are there healthy alternatives to DEI that we should consider, or do we throw the baby out with the bathwater and wipe our hands clean? What do you think? Share your thoughts in the comments. This month, Jennifer Richmond interviews Zander Keig in his update to his original talk on liberal approaches to diversity and inclusion, where he shared elegant ways to emphasize heterodox views in trans care. Zander updates us on how the conversation on trans identity has changed over the past 3 years. Zander continues to approach the conversation always centering the individual in the search for third spaces to navigate third rail issues. Zander reviews some big changes over the past 3 years, including the recently discussed science that suggests the rapid and rabid adherence to sex change as a solution for exploring gender identity may need reconsideration. Unfortunately, what has not changed is the polarization that continues to hijack the conversation, making genuine progress elusive. Zander, welcome to the Dissidents Podcast. You are a frequent guest on our podcast. Thank you for everything. And today, what we're going to be talking about is back in 2022, you gave one of the keynote talks for Counterweight, at the time Counterweight's Diversity and Inclusion Conference. And a lot has changed in 3 years, which is what we're going to talk about and kind of just get an update from you. But I have to say something first. Yeah, I know you. I consider us good friends, and as I was re-listening to your talk, your presentation, which by the way, for our listeners, it will be linked into this podcast episode, so you can go back and listen. One of the things that struck me, and it was so Zander, it was so you, and since 2022, and I've gotten to know you further, is you were always, even your book is about finding a third way, right? And you hadn't even written the book yet, but your whole presentation really looked at, and where I kind of wrote my notes down on this was talking about pronouns. You were talking about pronouns, and at the time, this idea of compelled speech versus, call me the right name and zim him whatever. And you're like, look, your answer was so beautifully elegant, and again, the perfect third way. Just call them their name. Call them their name. And so as the world was kind of turning upside down, and everyone was like, so anxious about either, compelled speech or getting it wrong, just call them your name. And so I know that since again, I know you, and I know you've since written a book on finding the third way. I know that in your update, it will include a similar strain, but let's go back to it's 2025. The world has changed quite a bit in 3 years. What have you seen that has changed since you gave your talk? And your talk, for our audience who hasn't gone back and seen it, you were really talking about heterodoxy in trans care versus orthodoxy in trans care. And again, heterodoxy being kind of that third way. How do we realize heterodoxy in trans care? So what would you say differently? What would you do differently? What is different 3 years on since we had this conversation?
Okay. Well, it's good to be back. It's good to see you again. Yes, I mean, a lot has changed. And I wrote down a few things that I noticed because I went back and I listened also. And so when we recorded that workshop, the National Health Services or Sciences, I forget what the S stands for in the NHS, I don't believe they had convened the Cass review team, Dr. Hilary Cass and her team. If they had, it was fairly new, because I think it was like a 4-year process, but we didn't know much about it over here yet. And so Since then, of course, their interim report came out, and their final report came out, and a lot of changes have happened over, in England. And of course, recently there was that Supreme Court ruling that talked about when woman and girl and sex is mentioned in the Equality Act, it means biological sex, right? And so that's even newer. That just happened. Also, I had mentioned the World Professional Association for Transgender Health, which is WPATH. When we spoke 3 years ago, the Standards of Care version 8 had not yet been released. And so we could talk a little bit about what's in that standard of care that's different from 7 and what are some of the controversies there. Because really, the central theme of the presentation 3 years ago was situated on a request that had been made of me for a training that I was doing. Right, I regularly do social care trainings within social work, primarily that have to do with working with transgender patients, clients in different settings, whether it be mental health or physical health settings. And somebody had said, could you include some more recent issues that are coming up that are a bit kind of third rail, right? What are some contemporary issues? And so when we spoke 3 years ago, it was about all of those issues, right? That were new. I had also talked about the Gender Dysphoria Alliance and my really brief association with them, and how that caused me to be removed as chair of a US PATH committee, the advocacy committee in particular, because I'd been given that big Advocate of the Year award from WPATH the year before. And so Gender Dysphoria Alliance doesn't exist anymore. And so the people from Gender Dysphoria Alliance moved over to what became the LGBT Courage Coalition, which now is the LGB Courage Coalition. So we could talk a little bit about that, although I don't have all the details. Of course, I was involved in that too much, to a very big degree. I also mentioned the differences between affirmative therapy, reparative or conversion therapy, and then providing that third way, as you mentioned, or third space, as I like to call it sometimes too, is exploratory therapy, and some of the controversy around that people likened exploratory therapy to conversion or reparative therapy. And so the Gender Exploratory Therapy Association no longer exists. A lot of its members, but not all, became part of a new organization called Therapy First, which has a new executive director and is not at all aligned with or linked to the organization GenSpect that was started by Stella O'Malley, a psychotherapist in Ireland. So we can talk a little bit about that. And then, of course, one of the main focuses of the Counterweight conference as a whole was DEI, right? And so much has happened in that world. In particular, most recently here in the United States, the executive order or orders from the Trump administration about, diversity, equity, and inclusion within the federal government and with contracts and grants and all these different things. So a lot has changed. Things are pretty much the same for me personally. I still live in Orlando, Florida. I'm still married, thank goodness. I'm still, living my best life and trying to enjoy things as much as possible that are around me, right? Not taking that for granted or advantage. So,
yeah. And you have tell everyone about your new book a little bit before we get into some of these changes.
Oh, sure. So I've edited anthologies over the last several years, and I decided that I would write my own book. Primarily, I was inspired to do that because my father had dementia, and I was his caregiver the last 5 years of his life, and I just started thinking about writing things down and making things available for others. And there was so much of life that my father lived that was not captured. And I thought, I maybe I'll just capture it and nobody but me will read it. It turns out people are reading it, so I'm thankful. But the book is called The Third Space, A Nonconformist's Guide to the universe. And this idea of the middle path or the third way, I refer to it as the third space. It's not unique to me. There's other books with the title The Third Space, but it's this idea of trying to find the option between, or the option outside, right, of the two warring factions, or the two two people in dispute. Yeah. In addition to being a social worker, I have a master's in conflict analysis and resolution, right? And so mediation, negotiation, this is part of our training, part of my training. And so this idea of there's always like this side and that side. And growing up in the Roman Catholic Church and thinking like you were either a Christian or some other religion, or you were an atheist. And I'm like, well, but aren't there other options? And so this has just been my way of living. It's like my personal moral compass, this looking for that third path, or the third way, or the third space. And so, yeah, I wrote that book. It's been a lot of fun. And I actually started a podcast in January to talk to other people who call themselves nonconformists or black sheep, or rebel rousers, or whatever it is. And so on Substack, I have the Third Space podcast. Oh, and in addition to that, since we spoke last, I'm not sure if I had started yet my Umbrella Hour podcast. We're starting the third year of that, so it's possible that I had, but we're still around and still recording interviews, and that's also on Substack at the Umbrella Hour. I'm not sure if it's podcast, but they're both on there, the Third Space podcast and the Umbrella Hour podcast. Yeah. Thank you for asking.
Of course. I think this is so important. This idea of this third space. Obviously, you live this idea, but I guess my question, in going back and kind of revisiting our conversation in 2022, do you see? You kind of gave us a rundown of what has happened. WPATH, and how now we've got the LGB Courage Coalition versus the Gender Dysphoria Alliance. Do you see a third space being carved out more so than when we had this conversation in 2022? And if so, how? And if not, what are you seeing instead?
Well, I think the Gender Dysphoria Alliance was a third space option because it was founded by trans people, and it included a lot of different voices. From psychologists and medical doctors and researchers and academics, nurses, social workers. And so there were a lot of people contributing to this process of looking at, like, what is gender dysphoria? How does it manifest differently across time and culture, and within, different populations of people? And then when that went away, and the founder of that, Aaron Kimberly, he's a psychiatric nurse up in Canada, a trans man, when he moved over to the LGBT Courage Coalition, that was also a type of third space, because it included gay, lesbian, bisexual, and trans people who were more heterodox in their thinking. But most of them were considered liberals. They were registered Democrats who voted for Democrat politicians. So it wasn't a far right organization, as people often referred to it as, or a conservative organization. Most of the people were just your standard, liberal, that noticed that the issues were moving further and further to the left, and leaving them so far towards the middle, or in the middle, that now they appeared to be on the right. But now with LGB Courage Coalition, right? No more T, so no more trans people. A lot of their messaging is actually, it's not friendly towards the trans community, even the adults, right? The thing that LGBT Courage Coalition was founded on was this idea that there was this group of LGBT adults who thought that young people should probably not be put on the road towards medicalization, right, for gender dysphoria treatment, right? Puberty blockers, cross-sex hormones, surgeries, these kinds of things. So it was this group of liberal LGBT people who said, maybe we should do something different. But now the LGBT Courage Coalition, I would say, has left the third space, and it has gone more towards actually being more on the conservative side, even though I would say the people that are running it are still probably card carrying, Democrats, or they're trying to change or reform the Democrat Party with not much luck. So I would imagine that most of their funding is coming from the right. So, so there's that issue of that's not a third space anymore. I'm not involved with it. The trans people I know who were, they're not involved with it at all anymore either. And I would imagine aren't even welcome unless they somehow renounced their own transness, right? Somebody like me, it's like I'd have to say, go off the testosterone and re-identify as a woman in order to be, to sort of fall in line with how they're kind of what I interpret as their messaging now, which I don't support. And so so that's an interesting shift.
Yeah, well, and so to give
there still aren't a lot of third spaces,
yeah,
right? It's
no,
like heterodox academy, obviously, in super liberal values, obviously. But when it comes to who's grabbing up a lot of social media airtime, who's getting quotations in the New York Times or on Fox News, right? It's going to be these more polarizing entities that are not third spaces at all. They're not welcome to people who think in nuance or gray areas or have questions or concerns about something that's considered settled science.
Mm-hmm, mm-hmm.
Yeah.
Well, okay, so Gender Dysphoria Alliance turned into LGBT Courage Coalition. Now they've dropped the
No. It didn't turn into. It's just that one of the two founders of Gender Dysphoria Alliance, they shut it down and they became involved with the LGBT Courage Coalition. Sorry, I'm getting tongue tied. Was starting right about the same time, and so they went into that, but it didn't become that. It was a completely separate entity.
So, for our audience, again, who has yet to listen to Zander's original presentation, at the time, you gave us a little information about WPATH, which was one of the biggest, trans care communities, right? And then US Path, which is the US community for WPATH. And you were a, what do you call it, a counselor for that or on the board? And because you're...
No.
Okay, tell me more. Tell me what I missed.
Okay, so WPATH is a professional association made up of individuals that are doctors and lawyers and researchers and practitioners of all types, mental health, legal, that is focused on transgender healthcare globally. And it was established in 1979 as the Harry Benjamin International Gender Dysphoria Association. So it's been around for a long time, just changed names. And they've been drafting something called the Standards of Care for medical gender transition since 1979. And the 8th version of that was published in 2023. So about a year after we spoke. And so I was involved with WPATH. I was a member of WPATH. And then when US Path was founded, which wasn't until like maybe 2016 or 17, I became a member of that just by default. Any WPATH member that lives in the United States is a member of US Path. And I attended the very first US Path conference, which was at UCLA. I was working for the US Navy at the time as the social worker for the transgender care team, which we had just stood up in 2016. And so they sent us to this training. I also served on the ethics committee for WPATH for a couple of years, and I was a faculty member at the Global Education Institute, which is the training body for WPATH to certify individuals, whether they're medical providers or behavioral health providers, in being, I guess, like experts in the standards of care. So not trans health as a total, but what the standards of care say. And I was certified in that, and I was also a faculty member or an instructor on the behavioral health side of the Global Education Institute. So it's a multi-process certification program. So that's how I was involved. And so in 2020, I was awarded the Advocate of the Year award by WPATH. And when US Path started in 2021, I believe, started adding committees in, right? Because the big WPATH had committees like the ethics committee that I was on, but US Path was a newer chapter, and they were just getting established. It took a little while, and they were putting out a call for people to be to nominate themselves to be a member of these committees. And so I signed up to be on the advocacy committee, and then I was contacted to say, we'd like you to be chair of that committee. And so then people, if they'll go and listen, they'll hear what happened to me as a member, as the chair of that committee.
Right.
Yes.
And
Yeah.
so do you think that US Path, W Path, what changes have you seen since 2022,
Mm,
2025? Where are they? What kind of advocacy are they promoting? What has
mm.
changed with them?
So I'm no longer a member of WPATH. I stayed on for 1 year after I was removed from my position to work on a project with the ethics committee to develop a grievance response process. Like if somebody lodged a complaint against us within the organization for violating some sort of ethical code, or what happened to me, which was an internal process, when it happened to me, there was no remedy. There was nothing for me to do. There was nobody to appeal to try and sort out, like, what happened? How did this happen? Why did this happen? Do I have any recourse at all? I did not. And so I went to the ethics committee and said, I'd like to be involved in a process to develop a formal way in which members of the organization can respond to internal and external claims that they have somehow, done something wrong and should be, exercised out of a committee or the organization as a total.
Hmm.
So I was let go from that committee, but I was also no longer called up to do trainings for the Global Education Institute, right? Because of this thing that I did that got me labeled as anti-trans. And so again, I mentioned previously, so WPATH put out the Standards of Care version 8
Yep.
in the summer, I believe, of 2023. And some interesting changes from Standards of Care, or SOC, to be easier to say, 7. SOC 8 included a Unix chapter, which has turned out to be quite controversial, talking about Unix, which, of course, in many cases, that's a religious regarding of males who are castrated,
Hmm.
right, who have had their testicles removed so that they don't have a lot of testosterone in their bodies, and they would make the male eunuchs in charge of the women's harems, these kinds of things,
Right. Right.
right? And so, or they'd sing at the higher voices, right? The castrati, I think they called them, from castration, right? With those young men with little boy voices, and right, so angelic sounding. That's how that happened. They also that's an interesting thing that if you want to hear more about it, like the eunuch chapter, they created a children's and an adolescent chapter that had some age limits in them. When it was going through the review process, what they call the Delphi process, I believe,
Mhm.
and it was all signed off on and ready to be released for public view, and then it was pulled back briefly, and the age limits, all but one age limit, was removed. So the age limit for puberty blockers and cross-sex hormones, and what they call top surgery, which is like breast augmentation or chest reconstruction, double mastectomy, different what they call bottom surgeries, or the genital reconstruction surgeries. They took all of the age limits off except for one, which is the phalloplasty surgery, which is a genital reconstruction surgery for people who are well, the way I would say it is, female sexed, but people might say female bodied or assigned female at birth, or, there's a lot of different, or trans man, a lot of different ways that people would say that. So that's interesting, removing the age limits. And of course, there's been some court battles that have been going on in Tennessee and in Alabama, because they want to put in bans on, or they want to put laws into place that say minors cannot take puberty blockers as a treatment for gender dysphoria. It is a treatment for precocious puberty. If you're like, your girl or boy is 4 or 5 and they're going through puberty, like that's out of sync, right? But so some of those court cases have wound their way through different levels. The Tennessee one, I believe, is the one that went to the Supreme Court, which we're waiting on a decision from. And the Alabama one is at maybe the appeal level, the regional level. And it was through these two cases, but particularly the Alabama case, that they did a discovery process of emails back and forth between, for example, WPATH, standards of care, what would you call that? The team of people who oversaw the standards of care version 8. So emails between them and researchers at Johns Hopkins that were commissioned to do some research, some meta research on children and adolescents, what the outcomes were for doing puberty blockers and cross-sex hormones. And also emails between WPATH standards of care people and members of staff at the Health and Human Services Department, the federal, during the Biden administration, and then also between Johns Hopkins and the HHS. And so some interesting news that came to light through all of that. So that I'd say that's a little bit about WPATH as far as some changes. WPATH is interesting. I find it interesting that they're staying completely tied to the same arguments that they were making 3 years ago and prior to that about, medical transition for all ages being medically necessary, life-saving, and yet what we've learned through the Johns Hopkins research process, the Cass, right, the Dr. Hilary Cass review and report team process in Britain, and through what's happened in, Sweden and Finland and, countries all around the world, Western countries, they're now starting to change the way they work with young people, minors in particular, who are presenting with gender incongruence or nonconformity or dysphoria or, different language that people use. They're no longer doing puberty blockers as a matter of course. And so, but it seems that here in the United States in particular, even though WPATH is global, I think most of the members are probably in the United States. They don't seem, if not convinced, they don't even seem to be publicly, maybe, they don't seem to be taking the line of maybe we should engage in more conversation with our colleagues across the pond to find out, like, what's going on over there. What led the Cass review team to come up with the recommendations that now the NHS is putting into practice? What happened in Sweden? What happened in Finland? What happened, in these other countries? What's happening in Australia? Germany and France? What's happening? Why are we? It's like we've planted a flag in the gender affirming care is life-saving and medically necessary, and to the point that I've heard medical professionals say that Dr. Hilary Cass is a quack, doesn't know what she's talking about. And I'm like, she is a preeminent British pediatrician who came out of retirement, I think, to take this process on. Was like not a person who was opposed to, you know, gender nonconformity or even, trans stuff, right? In older teenagers perhaps and adults, but it's a complete rejection. And it's like, well, what about Sweden? What about Finland? And they're just like,
Right.
they either are like, what are you talking about? Like they'd say, oh, they don't know anything about it, which is possibly true for a lot of people. They don't know that all these countries are making these changes with respect to young people and what they can access medically. It's like they either don't know or they're saying like it's wrong, it's incorrect, they're wrong, right? So these places where people are used to say, the most liberal, the most generous in their way that they treat trans people, the people on the cutting edge, the people who started, right? Like it was in Scandinavia that they first started doing these kinds of treatments, right? And with children, right, with the Dutch protocol, like this is all like that part of the world, right? The Western European world were the champions of all of this. And now they're going, wait a minute, we're looking at this longitudinal research based on the fact that we can look at every single patient that's ever passed through our clinics because they have socialized medicine and centralized data. And so they look at it over the long term, 20, 30, 40, 50 years, and they're like, oh, yeah, these outcomes aren't what we wanted or hoped or expected.
Mm-hmm.
And so they're doing what they're doing. They're slowing things down, they're changing things. And it's I think it's quite disappointing that if not WPATH as an organization, but people that I know that are leaders in WPATH are just unwilling to take into consideration any of the findings of those other countries and their medical bodies. These aren't just, it's not like just some individual thought, oh, this shouldn't be happening and I'm going to force the government to change. No, this was like the governing medical body of the country did the research, right? It wasn't like here in the United States, people will say, well, gender affirming care is supported by all of the medical associations or the medical groups. What they mean is the American Medical Association, the American Academy of Pediatrics. Those aren't medical groups, right? Those are professional associations. They're not advocates for consumers. They're not patient advocate organizations. They're doctor advocate organizations, right? So that's a very different thing. The entities like NHS and the same similar thing in Sweden and Finland, these other countries, these are consumer protection organizations or bodies. These are government bodies. They're not even NGOs or nonprofits. They're part of the government.
Mm-hmm.
And so why would these like super liberal governments all of a sudden become transphobic? Like it makes no sense, but that's how it gets talked about. And I find that disheartening and disingenuous. I think it's unfortunate.
So I've got two questions on that. Can you give us a quick recap for those of us who don't know about the new studies that are coming out, both the Johns Hopkins studies and this CAS study in the UK? Give us a quick summary of what were the findings? What did they?
Sure.
Yeah.
Well, I don't know all of the granular details of this, but I know more than just the layperson. So what I can say is that when WPATH was working on the Standards of Care version 8, and they knew that they were going to have this children's chapter and this adolescent chapter, they commissioned Johns Hopkins University, a research team, to look at all of the research on children and adolescents who had medically transitioned using puberty blockers and or cross-sex hormones. And they wanted to know, were the outcomes improved? Meaning, did their depression scores go down? Did their anxiety scores go down? Did their suicidal ideation go down. And were they, how were they functioning in society, right? Were they well adjusted and employed and in relationships? How were they doing? And so they went and they looked at all the research that is available, and unfortunately there's not a lot. And all the research that most of the research that is available is small cohorts. There's a loss to follow up. There's a lot of people who drop out of the research. There's a lot of issues. And so they basically came to the conclusion that the outcomes weren't good, or as good as you would hope. And so WPATH, my understanding based on the correspondence via email that was found in discovery through the Alabama court case, is that WPATH standards of care, team members were like, thank you, but no thank you. And they said, we commissioned that research, so you can't publish it anywhere. And which I think ruffled the feathers of the Johns Hopkins people, which I think is probably why they got in touch with the Health and Human Services people at the federal government level. But they basically were like, the outcomes, we didn't find the outcomes that we were looking for. The Dutch protocol, which was the original research done, where they followed a small group of very young people who were identifying as some sort of cross-sex identification or something like that, and they put them on puberty blockers, and then they tracked them. And the reason they did that is because they did follow-up research on the trans adults and found that there were still a number of them that weren't well adjusted. And they wanted to find out, like, why we gave them everything they said they wanted. We gave them surgeries, we gave them hormones, we gave them access to new identity documents. Like, why aren't their lives better? And one of the primary reasons that was suspected for this was that more so in what would be called trans women than trans men like me, trans women. So people who went through a male puberty. And so there's just so much that taking estradiol or estrogen, can do to undo what happens in male puberty. And so the trans women were much more visible in society as being trans, right? Like, I don't stick out in the same way that many trans women do. And so there are lots of trans women who don't stick out, but people don't know that they're there. But the ones who stick out, like, you notice them. So the hypothesis was, well, what if we stop their puberty? If we stopped their puberty and they didn't masculinize or feminize on the other side, then they wouldn't have to do as many surgeries. They wouldn't, right? There's all kinds of things. So they put them on these puberty blockers, and then they were following them. And I'd say, the outcome of that was okay, but it was good enough that it started to take off around the world, and it came here to the United States to a children's hospital in Boston. And the psychologist who was the one who went over there and learned about it and brought it back is now one of the, if you could call her such, whistleblower, Laura Edwards Leeper. She's a psychologist and a WPATH member and a co-author on, I believe, the adolescent chapter of Standards of Care, version 8, and has been very, very vocal in her concerns about things with puberty blockers and the such. So there's that issue with the CAS review. So the National Health, I think it's Services in Britain, I believe, my understanding is that there were a number of complaints coming from the Tavistock Clinic, which was a large clinic in London that had a gender clinic in it where they saw adults and adolescents and children, and or maybe it's just minors, I'm not exactly sure. But there were staff there who had some issues with how things were functioning. And I guess there were enough people that had enough concerns, and then some patients started to get more attention in the media, and we're saying, like, I should have never been transitioned. They didn't treat my depression, or they didn't treat my trauma. They just transitioned me. And so I guess that started the process where they thought, maybe we should look into this more closely. And they asked Dr. Hilary Cass, again, a preeminent pediatrician in Britain, to head it and gather a bunch of people together. They also had other organizations that were looking at research and doing all that for them, right? To keep some of it in-house and some of it out of house, um, probably to, make sure that there's, less bias, and who knows why. But that's not uncommon. And so at the end of that report, that they sent back off to the NHS, and even the interim report, it was pretty clear that they were saying, like, the outcomes are poor. They're fairly poor. The outcomes, they're not what you would expect given the argument for why to do it. The reason to give puberty blockers is to alleviate all of the psychosocial distress in the young person. And it was turning out like that wasn't actually the case for many. And so what I believe has happened is the NHS has now said no puberty blockers for minors, and cross-sex hormones can start, I think, maybe 16 or 17. And they're starting a study. They're going to enroll young people who fit a very particular criteria, like the Dutch protocol did, and they're going to study them, meaning they're going to test their bones and their brains, because the puberty blockers have all kinds of adverse physical effects, and so they're going to be studying them. And so they've been adding people to the team of who's going to be studying them. So, and of course, in all the other countries, people can look up, Sweden and Finland and Norway and Holland and Denmark and just all the different things they're doing. Australia, there's a lot of things happening right now around, even in Germany and France. Things are, there. Some places are looking at making some changes. Some places are in the process of making changes. Some have already made those changes. And so a lot has happened in the last 3 years.
So my second question then is, you said WPATH, and being primarily, a lot of Americans involved in that. So WPATH, US Path. One of the reasons, this is my question to you, is one of the reasons that maybe they're not paying attention to these other studies in other countries. So maybe is one of the reasons that they are digging their heels in, and not acknowledging these other research studies. Is it political? Is it because, we've seen this kind of pushback, particularly, this year, 2025, with the new administration, that it's almost like a political statement more than it is a statement of care.
Yeah. Yeah. I mean, again, it's really interesting. It's either the denouncing of, like, for example, Dr. Hilary Cass and her review team and process and the final report. And then some of the other countries, it's as if, yeah, it's not that they don't know about it, at that higher level within WPATH. It's if they don't talk about it, then fewer people will learn about it, right? It's like the media. If you can control the information that's available, then people won't have access to it, because the only way to access the information is going to then be through, foreign news services, which you might not be able to read, right? Because it'll be in a different language, or what would be considered conservative news outlets, and you definitely don't want to read those, right? So they're only going to it's that echo chamber thing. They're only going to get exposed to what WPATH puts out there, and so they definitely went directly after Hilary Cass and the Cass review and the final report, and they tried to knock that down. And I think they did it successfully, because some people from Yale put out a white paper, that's like denouncing or debunking it, and it's like that they didn't actually do that. They just made statements saying we're denouncing and debunking it, but they didn't actually they denounced it, but they didn't debunk it.
Right.
Because it's science, right? And they are lawyers, and so it's this interesting thing about if you want to truly take science on toe to toe, then you run your own study. and you get different, you look for different results. But they're not going to do that. Because it's not going to work out well for them. So they just want to do the sort of smear the person, smear the process, smear the final product. And, it was probably within the last year, maybe even the last 6 months, that the New York Times ran an article where they were talking about a National Institute for Health funded study that included 3, maybe 4 children's hospitals in the United States with multiple medical providers involved in the research and many, many patients. I don't know how many, dozens or 100 or 2 or whatever patients. And it's been in operation now for a number of years, and they were given a lot of money in the millions. And so this reporter from the New York Times was asking one of or maybe the primary principal investigator, a physician in Los Angeles, at a children's hospital, and she was like, "Why haven't you published any of your findings? Like, you've been working on this research project now for multiple years, and you haven't published beyond maybe one simple little thing." And the response back was, because we don't want the results weaponized. What that means is the results are poor. The outcomes aren't what they want them to be. They're not what they hope they'd be. They're not what they expected them to be. And so they're not going to publish. But when you get several millions of dollars from the federal government, it should be that you publish your findings so that other people can read about it and see if there were some changes they could make to the study and rerun it, or if there's different ways they could look at the outcomes. Like, what was going on? Was there a really good balance of race and ethnicity and socioeconomics, blah, 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 right? Family support, not family support. But instead, they're just withholding. They're withholding that information. And even the New York Times is like, well, that seems like a problem. Like, maybe you should be publishing. And the response to that by organizations like GLAAD, what used to be called the Gay and Lesbian Alliance Against Defamation, which is not that anymore, but it's still called GLAAD. They were very angry at the New York Times, and have been on many occasions over the last couple of years, for writing anything that's not absolutely affirming and positive. If they have any, like, I wonder why, or that's curious, or I'd like to know more about that, they're like, you're transphobic, and people should cancel their subscriptions. I mean, so there is no third space. There's only left, right, and third rail. The third space is a rail, like on the railroads, right? In the subways, that if you touch it, stuff burns up. It's unfortunate in that way. I talk to people all the time, and I'll be like, well, they'll be like, oh, this and that's transphobic, and this and that is transphobic. In Florida, we have the same thing. No minors can transition. And I'm like, well, Florida's doing the same thing that Sweden and I think Finland, and I was naming, Britain, and they were like, what? They don't even know, because the regular news isn't going to talk about it, mainstream, and the LGBT organizations aren't going to talk about it. Even the professional ones that are medical, right, focused, they're not going to talk about it, because they don't want to draw attention to it.
Right. Well,
Yeah.
okay. So one more question that takes me back to this idea of exploratory therapy, which you said has basically also, that was one of the third spaces that you had mentioned.
Yeah.
And just to kind of remind our audience, so there's 3 kinds of therapy with regards to trans care. There's gender affirming therapy, which we've been talking about. There's reparative or conversion therapy, which not good. That usually has a bit of a religious bent. But you had introduced in your presentation exploratory therapy, and it sounded like it was very promising because it focused on the client, and it was not, it was focused on the individual. Like, let's see who you are. Like, let's explore this a little bit more before we just go straight to a medical solution. And I know that at the time, though, back even in 2022, some of these people who won't allow you to even have this conversation. We're calling it conversion therapy, even though it wasn't. And you just said at the beginning that now it's become therapy first, but therapy, and you mentioned GenSpect, which, by the way, for our listeners, GenSpect is an organization that you and I have spoken with on podcasts before, an
Yeah.
organization
Yeah.
that is more this exploratory, like, let's see what's going on here before we go the medical route. So it's not necessarily unaffirming, someone who might feel that they, are identify or want to identify differently. It's just saying, let's not go straight to the medical path right before figuring
Yeah.
things out.
Yeah.
So what is going on? You said it's moved from
Okay.
exploratory therapy to therapy first. What is therapy first? Is exploratory therapy
Yeah.
even a thing anymore? Tell me more about that.
Yeah. Well, one of the things I want to say just to set this up is that some of the I had an opportunity a few years ago to facilitate some kind of behind closed doors discussions between between leaders of a trans organization and leaders of a what would be considered a transphobic
Right.
organization, right? And the funny thing, of course, is that they were mostly in agreement with each other. And the reason that I wanted to mention that is because let's take WPATH, right? WPATH is a professional association that puts out very few communications,
Hmm.
right? And so the majority of people who are talking about things that are trans healthcare, they might be members of WPATH, but they're not speaking on behalf of WPATH. But because they're affiliated with WPATH, what ends up happening is people see, oh, that person is aligned with that organization and they're espousing these sentiments. Therefore, WPATH must support that. And so they become anti WPATH and they assume WPATH believes in all of these things like, you know, gender affirming care with no questions asked. Well, if you read the standards of care, you would see that there are many questions asked,
Hmm.
right?
Hmm.
Biopsychosocial assessment is a component of the standards of care in order to access, hormones and surgeries. So they're not like do whatever you want. You're in charge of your own care. On the same token, anybody who might be questioning the informed consent or harm reduction model of accessing hormones without having any biopsychosocial assessment, again, not psychotherapy, just an assessment, right? As we talked before, and that people can listen, right? Just that assessment. They think, oh, you're anti-trans, and oh, I've seen you. You were at a GenSpec conference, or you were on a podcast, or you affiliate with those people. You're connected to them on social media. Therefore, GenSpec believes that nobody's trans and nobody should transition, and therefore GenSpec gets labeled anti-trans,
Hmm.
right? And so just because somebody is affiliated with or is involved in a program, right? Like there might be parents who are very upset that their child is claiming to be, trans and wants to do a medical transition. And they might be at a GenSpec sponsored parents group. And there might be other people in that group who get very upset with the way they're talking. And then they go to the media or they go to other people or they write a Substack and they say, there's a bunch of hateful anti-trans people in the right. That's what ends up happening. And so it's like WPATH is not as bad as the people who are against it think it is, and GenSpect is not as bad as the people who are against it think it is.
Right.
Right. So that's one thing to keep in mind. Because I have been, at a GenSpect conference, and because I've been on podcasts with Stella O'Malley, who founded GenSpect, they automatically label me as a trans person who does trans advocacy and trans social care work, and for years was seeing trans clients and patients. I get labeled as transphobic. That's how ridiculous it is. So the really unfortunate thing is that when Gender Exploratory Therapy Association was founded, they should have never called it that. And the reason they should have never called it that is because the foundation of good psychotherapy is exploration.
Mm-hmm.
Like almost all, if not all, therapy models, right? There's so many. I'm not even gonna, they have exploration as a foundation or a component of them, right? Oh, you have that feeling. Where might it be coming from? Oh, you have that thought. Where might it be coming from? What does it mean? What do you want to do? And so, why would it be any different with a feeling distress about our sex, the roles, sex roles that are expected of us, or the gender roles, or our gender expression, or our sexual orientation, or all these things, right? Why can't we? But I think what ended up happening is some people, some therapists refer to themselves as gender exploratory therapists, but they were very negative on trans people and transition, and they really were trying to dissuade their people, their clients and patients from a trans identity and from going on doing a transition. And so that's the opposite of affirming, right? And so, but people that on the other side were affirming, but ignoring in many cases, not all, but in many cases, that they had, trauma they hadn't processed, that they had anxiety and depression, disorders that they weren't treating, right? And so that sort of third space is all therapy and how it should work, which is, you know, patient centered and or client centered, and working on like what brings you in today, where is the dysfunction showing up for them in their lives, and what changes would they like to make, and what barriers do they have to making those changes that are internal and external barriers, and helping them work through that, and providing them with access to people and resources and programs and services. Like that's what happens that's what you should be doing, whether you're working with a patient who's going on dialysis or needing organ transplant or a knee surgery or adopting a kid. Like we put people through the process of getting as much information as possible so we know how to support them and how to resource them. And why should trans people get any less care?
Mm-hmm.
Right? Why should we not get the same level of care? Right? So we have to figure out that third space is we don't want, what they call the gatekeeping, which is you have to come see me every week for 2 years before I write a letter for you. Okay, now that's ridiculous. The other extreme is come into my clinic. After 20 or 30 minutes, you're walking out with a prescription for your hormones.
Mm-hmm.
Like we need something in between. And at the standards of care outside of like the eunuch chapter, of course, and these age limit issues, but the standards of care have always been really good at putting in safety rails,
Mm-hmm.
right? To make sure that people, it's like, yeah, somebody wants surgery. Okay, good. Maybe you're going to send them off with a letter to the surgeon, but do they know how they're going to get home from the surgeon? Do they know how they're going to manage after their surgery? They're going to need help around the house. They're not going to be able to lift. They're not going to be able to bend. They're not going to be able to bathe. They're not going to be able to, maybe prepare meals. Maybe they have to go up and down stairs. That's not going to work really well after some surgeries. So it's like figuring out all of those things. Why should there be any less care taken in our treatment? That's how I see it. As a medical social worker, I say that our care and our treatment is just as important, and we should have all the same safety rails put in like everybody else.
And so with WPATH, they have those guardrails in their standards of care. The thing that is concerning to some people, if I heard you right, is really the problem with the kind of the age limit. That's where they're getting that's where they're digging in their heels, even though their standards of care
Yeah.
in general have those guardrails,
Yeah.
whether or not they're being implemented or not. But it's really more the question of age that has gotten WPATH kind of a bad.
Yeah. Yeah.
Right.
It's like there's two or more groups of people that are mad at WPATH. And so there's a group of people that are mad at WPATH because they took age limits off of things. And they put in the eunuch chapter and
That's
these
that's
kinds of
the
things.
story. I mean,
But then there's also people that are angry at WPATH because they don't think there should be any safety rails. They don't think there should be any. I think they think people should be able to just walk up to like a vending machine and pop out some hormones. Or just, it's like, well, if I wanted a nose job, I could just go see a plastic surgeon and get a nose job. And it's like, well, yeah, but that's a cosmetic surgery that insurance doesn't cover. So if you want a medically necessary surgery, that's elective, not cosmetic, it's still elective because it's not an emergency surgery. It's not like your appendix is ready to burst and that's an emergency surgery, right? But it's not cosmetic. Insurance does cover it. Well, there's protocol. There's hoops you have to jump through. And so there are people who are unhappy with any hoops at all, and then there are people who say there need to be like 100 more hoops. And so, of course, this is not going to work, right? We're not going to be able to find this third space with access to medical transition for trans people and adults in particular. If these two factions are the ones that are at war with each other and getting the most attention. There's many people, probably more, that are in the middle going, why are we having a problem solving this issue? Like, that's just standard medical process or procedure or practice. Like, why are people freaking out about this? It's like, well, because they're activists. They're either pro transition activists, no guardrails, no safety rails, or pro no transition, period, for no reason. Trans people don't exist, and nobody should be mutilating their bodies. And this kind of thing. Or it goes back to cosmetic. If you want that, you pay for it and you're on your own, which is how it used to be, right? We were on our own. I started transition before it was covered by medical insurance.
Yeah. Well, then also I think,
that was 20 years ago.
Yeah. Yeah, you are a trailblazer, as per usual. And
there were many. I have a friend who's in his 80s. He's been on testosterone 50 years.
Really?
So, no, I mean, there are trans people that were transitioning through hormones and surgery in the 40s. This is not new. It's just that one of the problems is that even though people have been medically transitioning all around the world for all these years, there's a lack of research that's done. There was so much focus and attention on getting people access to the care that they forgot to do research along the way. And now they're coming back and doing research, and unfortunately the findings aren't good.
Yeah, I would
more often than not.
That's the one thing that I'd say in this conversation that I think is from 2022 is that research, even if the United States is not acknowledging it, the research is happening. And so there is that care going on. And hopefully I hope we will find the third space in order to be able to talk about it in a way that's helpful. You mentioned in the last talk, we have a very low health literacy. And the fact that we can't even talk about these studies only compounds the problem that our health literacy is really, if I don't know if it's in decline because I don't know if it ever was there to begin with, but it's lacking in a large way.
Listen, I went to the World Health Organization website just before getting on this presentation because I had, as I had stated in the previous recording, I had only been looking at the US and I wanted to have a more global perspective. And so I went to the World Health Organization and read what they had to say about health literacy. And I couldn't find any percentages. But you know what I did find? What I did find is that the research shows that health literacy has more of an impact on health outcomes than socioeconomic class and education, right? We would think, rich people have better access to healthcare and therefore they're healthier people, perhaps. No, it's all about health literacy, right? It's a fact that if you don't know how to read medical and legal language documentation, you're not going to understand all those forms you're signing when you go to the doctor's office, in particular the informed consent form. And for me, that's another part of the issue. Why, it's not just us. The informed consent process is truncated and circumvented in a lot of medical practice settings. It's just, here's a clipboard, it's full of a bunch of pieces of paper, and nobody's actually going over point by point your informed consent form. You don't really find out that you signed off on something as an art, not a science, until something bad happens. Right? Because we trust medical providers. We trust them. And so, but people don't know what they're reading. It's not in layman's terms. And even if it was, there still can be language barriers as far as what language it's printed in and what language is the primary language of the reader. And so it's considered a major problem worldwide by the World Health Organization, this low rates of health literacy.
Mm-hmm.
And I've thought over the years of doing health literacy trainings where I'm specifically talking about the trans community, but then I just broaden out rather than going broad and narrow to trans. I'm thinking start with trans and then go broader and say, like, this is a massive issue that there should be much more attention paid to it. And we can't be the exception, right? If our health literacy matches the health literacy of everybody else,
Mm-hmm.
then not only are we being offered medical treatments that we don't understand, we're being offered those treatments and recommended those treatments by people who don't even have a full understanding of us as the patient, because nobody's done the biopsychosocial assessment. Let me say one thing. I was talking to a medical doctor who is very high up in leadership at WPATH. I won't say names or position because it'll give it away, but let's just say a doctor very high up in WPATH. And we were on a meeting together once, and I said, I think everybody should have at least at a minimum biopsychosocial assessment with a social worker. And she said to me, "What's a biopsychosocial assessment?" And I was like, okay, maybe she just doesn't understand the terminology. Maybe that's like a social work thing. Turns out, no, that's a thing. But it's in the EHR, the electronic health record. It's like click, 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 drop down, drop down, drop down, right? They're either asking or not asking and just filling in. And I know this because I worked in medical settings for, over a decade. And it's very unfortunate, the lack of information gathering that can really help, the process and the patient and the procedure or whatever they're going through. It can help them. It's not meant to deprive them of anything. It's not meant to privilege one person over another. It's really meant to make sure that all of the people that you're going to see have a better and fuller understanding of who you are and what your needs are, so that they can put whatever into place that they need to put into place. And that is not happening, except in very large healthcare systems and countries that have, socialized medicine where they have access to all of these services. But a lot of people in the United States are just going to a community clinic that might have peer support specialists, and maybe they have a therapist that you see if you have mental health, issues that you want to talk to them about. But there's not necessarily a person who is a case manager or a care coordinator who's tracking them and connecting them and resourcing them. Case managers in particular, whether it's a nurse or a social worker, are missing in a lot of these places. And that, I think, right, I'm biased, of course, but as a patient, I've noticed the difference when I've gone to certain healthcare settings to get access to my various types of trans-related healthcare. I can tell the difference between when they do and don't have a case manager and how that impacts me and my well-being through that process. So, yeah.
I think that's so important.
Yeah.
I hope that you do that. And there's so much there that I hope that we actually have a separate podcast on health literacy. I mean, I've got so much to say about that. I just think that, again, I'm not sure we ever had it, but I think that to the extent that we did, I think it's getting worse. So let's put that sometime soon.
Absolutely. I'd love to do more on that. So let's do that.
Let's do it. All right. And in the meantime, thank you for your update. I'm sad. I'm a little bit, I guess, to the extent that we're bringing, we see science kind of catching up to the cultural conversation. The fact that we are not accepting some of that into the cultural conversation or creating a third space around that cultural conversation. The fact that you are still, as a heterodox thinker in this space, still being labeled 3 years later as a transphobe in some spaces is not like really
I
positive,
know.
but
I mean, it's like read the tea leaves, people. Like 26 states, I believe, last time I looked, have either enacted, are in the process of enacting, or what they have enacted is being appealed to stop minors from getting puberty blockers and cross-sex hormones. 26 states. So it's, I think what it's going to be, it's like there's a significant number of people within the trans and quote ally community they're basically throwing a temper tantrum, and they're going to have to be picked up off the ground and put in a timeout in order to let the adults, uh, work things out, because they're not going to stop what's happening. But my prediction is that because of the refusal to accept any part of this research that's been going on, or the meta-analysis of prior research that's been happening, their refusal to acknowledge it is actually going to make things worse for trans people, because it's infuriating. It's like it's gaslighting. It's crazy making for people that are on the outside looking in, going, "Are you crazy? How can you not see that taking that medication can have all of these possible contraindications or implications for the health and well-being of a child? How can you just say give them puberty blockers because it'll stop this one little distress, and well, if they end up, blind, or with their skeleton all disfigured, or, out of sync socially with their peers, or, sterilized and infertile, like, well, that's just, that's, we treat children who have cancer with chemotherapy, and that makes them sterile and infertile. That's what somebody said to me. They likened puberty blockers for gender distress for treatment of cancer in children. That's unacceptable to me. Unacceptable.
Hmm.
But that's the frame that people are working off of.
Right, right.
And I think it's going to end up, I think the pendulum is going to swing so far to the other side that it's going to be, it'll start eroding on all kinds of progress that was made over the course of like 20, 30, 40 years at a very slow clip. It's already starting to do that. And I don't see any end, because when LGBT Courage Coalition becomes LGB Courage Coalition, that shows me that erosion is going to keep going.
Mhm,
It's
mhm,
gonna it's gonna
mhm.
cut trans people out completely. Nobody should be transitioning, period, for any reason.
Right, right, right.
Yeah,
Yeah, the
yeah.
pendulum doesn't seem to swing at a manageable pace ever. So
No, that's the way it is, because it's two opposites. And so that's why we need the majority of people who reside in this third space, and do on most issues. We need more and more of us. And I think the time now, I think we've hit a tipping point, and I think the prospect of losing your job and being excommunicated from your social circles and things is becoming less and less of a legitimate threat. More and more people are like, okay, whatever. I'm willing to take that chance. And it's not impacting them how it was impacting people, 3, 4, 5 years ago.
that's a good
It's just
positive
not
thing.
working.
Yeah, I mean, it's positive that enough people now feel more comfortable, that they're not as cowed into silence as maybe they
Yeah,
were. So that's a positive change. Although
yeah,
again,
yeah,
still all over the place. So
yeah. I can see that in social work. The heterodox social work group
yes.
is made up of almost exclusively academics, researchers, teachers, writers, academic writers, and the articles that are starting to come out in social work academic journals, um, taking to task all of this critical social justice stuff that's come into social work. They're pulling that stuff apart. right? Because it takes a few years for all that stuff to wind its way through the academic press, and it's just coming out in droves now. And many of those people are affiliated with the heterodox academy, so thank goodness,
Yeah.
right? Thank goodness. Yeah.
Well, Zander, have a wonderful rest of your week. Thank you so much for the time, and we will talk again about when we can do something on health literacy. I'm really excited and interested to hear more.
Absolutely. I look forward to it. It's good to see you again. Thanks for having me on.
You too.
Thank you for listening. Please consider donating to the Institute for Liberal Values, a 501c3 nonprofit organization at ilvalues.org. All donations go to support our continued programming to realize our mission to provide the skills and support required to build community where there has been division, to encourage free expression where there has been censorship, and to foster optimism where there is fear.